Hi, I'm Paige Bucket, and I'll be giving an overview of systemic lupus erythematosus, SLE for short, and its treatment strategies. So, to begin, SLE is an incurable autoimmune disease where the patient's immune system creates autoantibodies that cause chronic inflammation and damage to various organs and tissues throughout the body, such as the skin, the heart, the blood, the lungs, and the dysregulated immune response that leads to SLE includes a loss of tolerance that allows autoreactive T and B cells to persist, and also an overreactive type 1 interferon response that further drives these autoreactive lymphocytes. And also, there's dysfunction of the classical complement pathway. And one of these major complications is called lupus nephritis, which is when the autoantibodies target the kidneys and cause significant inflammation that can lead to decreased kidney function or even failure. And this affects about 25% to 60% of SLE patients and can lead to death. So lupus is detected in multiple ways, such as looking at its physical manifestations like a butterfly rash or mouth sores, but also urine and blood tests are conducted to look at complete blood counts, measure autoantibodies such as anti-nuclear antibodies, and also biopsies and imaging tests are performed to check for inflammation or even necrosis in various organs. So there are multiple drugs in the standard of care for SLE. And the most commonly used one here is called hydroxychloroquine, which is an anti-malarial, but in SLE it works by modulating antigen presentation and toll-like receptor signaling. And then glucocorticosteroids are also commonly prescribed because they have anti-inflammatory effects. In addition to this, immunosuppressant drugs like methotrexate and cyclophosphamide are used. However, the standard of care varies based on the organs that are being affected, and there's only currently one biologic drug that is officially put in the standard of care for SLE, and that's called belimumab, but rituximab is another biologic drug that's commonly used, and it's an anti-CD20 antibody that targets circulating B cells. So, talk about belimumab a little more. It's a fully human monoclonal antibody that targets B cell activating factor, shortened to BAFF. And belimumab was developed to target dysregulated B cell activation that underlies SLE. And it was discovered in 1999, and they found that elevated BAFF levels were associated with the survival of the autoreactive B cells and increased production of autoantibodies. And they found that elevated BAFF also correlates with lupus nephritis, and they found that in both patients and in lupus-prone mouse models, and that highlighted BAFF as a potential therapeutic target. So belimumab was then developed by Human Genome Sciences, and it was the first monoclonal antibody designed to neutralize soluble BAFF. And by inhibiting BAFF signaling, it reduces the survival of the autoreactive B cells and decreases autoantibody production. So, in this trial, the efficacy of belimumab in treating lupus nephritis was studied in a double-blind, placebo-controlled trial over 2 years, with 224 patients receiving belimumab and the other 224 receiving placebo. And one key result that showed the therapeutic efficacy of belimumab was its primary efficacy renal response in week 104, so that's the end of the trial, and the belimumab group had a 43% response rate compared to 32% of the placebo patients. And then furthermore, the belimumab treated patients were more likely to get a complete renal response at week 104 with 30% versus 20% for the placebo group. So this shows a sustained advantage for the belimumab group through week 104 over the placebo group. So finally, precision medicine can improve outcomes by utilizing serological biomarkers that were identified in a 2024 study that involved 122 SLE patients with lupus nephritis. and they evaluated the patient's anti-double-stranded DNA and anti-SSA/Ro60 positivity, and it was shown to be a potential predictive marker for the success of belimumab in treating lupus nephritis. So patients that had a baseline positivity for anti-double-stranded DNA were less likely to experience NRR, which is no renal response, at 6 months. So they only had a 29% in comparison to patients that had anti-SSA/Ro60 positivity that predicted a higher no renal response, which was 75% for that group. So identifying these serotypes enables tailored treatment to optimize the use of belimumab and improve patient outcomes by targeting those that are more likely to have a benefit from the therapy. So thank you.